Layers of scrotum. Skin, dartos muscle, external spermatic fascia, cremasteric muscle, internal spermatic fascia. Layers of testis. Layers of scrotum plus 1. Tunica vaginalis parietal and visceral. 2. Tunica albuginea. 3. Tunica vasculosa innermost. Structure of testis. 200 to 300 lobules, 2 to 3 seminiferous tubules, rete testis, efferent ductual, epididymis, vas deferent. Blood supply of testis. Testicular artery, branch of abdominal aorta. Veins, forms pampiniform plexus. Right testicular vein drain into IVC. And left testicular vein drain into renal vein. Which side testicular vein drains at right angle and have longer course? Left testicular vein. Lymphatic drainage of testis. Left testis, para-aortic group. Right, interaortocaval group. Testis develop in genital ridge retroperitoneal. Trigger for descent of testis. 1. Differential growth of abdominal wall. 2. Pull of gubernaculum. 3. Hormonal factors. Timeline for descent of testis. Intrauterine month. 3 testis begin to descend. 6 lies in iliac fossa. 7 lies in inguinal canal. 8 lies in superficial ring. 9 reaches scrotum. Most common site of arrest of undescended testis. Inguinal canal. Which side testis commonly undescended? Right greater than left. Bilateral undescended testis is called cryptorchidism. What are changes seen in undescended testis? 1. Lesser volume. 2. High risk of seminoma. 3. Decreased spermatogenesis. 4. Normal 2 degrees sexual characters. 5. Higher the testis, more histo changes. Which among these is affected more in undescended testis, Sertoli cell or Leydig cell? Sertoli cells affected more, so decreased spermatogenesis. Leydig cell affected less, so normal secondary sexual characters. Complications of undescended testis. Testis, trauma, epididymo-orchitis, sterility, torsion, indirect inguinal hernia (MC), seminoma. Presentation of undescended testis. Reported by mother, scrotal rugosities absent, inguinal testis palpable. Investigation of undescended testis. Inguinal canal USG. Intra-abdominal, diagnostic laparoscopy IOC. Management of undescended testis. Spontaneous descent can occur till 5 months of age, so surgery not done before this. Ideal surgery time equals 6 to 12 months. Management protocol for cryptorchidism. Give single dose beta HCG, if no response, anorexia. If testosterone, FSH, LH level increase, do laparoscopic exploration. Management protocol for unilateral undescended testis. Do laparoscopy. 1. If intra-abdominal, viable testis, orchidopexy. If necrotic, rudimentary, orchidectomy. 2. If vessels seen exiting deep ring, do inguinal exploration. 3. If blind ending vessels, monorchia or intrauterine torsion. Types of orchidopexy. 1. Fowler-Stevens. 2. Keighley-Toric. 3. Silber, best method. Fowler-Stevens orchidopexy. Stage 1 high ligation of testicular vessels plus mobilization of testis into inguinal canal. Stage 2 mobilization of testis into scrotum after few weeks. Silber orchidopexy. Testis mobilized to scrotum, testicular vessels cut and microvascular anastomosis with branches of internal iliac. What's ectopic testis? Testis deviate from normal path of descent. MC site, superficial inguinal pouch. Management, orchidopexy. What's retractile testis? Testis occasionally jumps into inguinal canal and returns to scrotum later, normal. What's testicular torsion? Occurs when testis rotates, twisting the spermatic cord, hence blood supply is reduced, causing severe sudden pain and swelling. Risk factors for testicular torsion. 1. Bell clapper testis. 2. Testicular inversion. 3. Undescended testis. 4. Torsion of cyst of Morgagni. 5. testis separating from epididymis. Clinical features of testicular torsion. Young male, acute onset severe scrotal pain, acute onset swelling. Differential diagnosis for testicular torsion. Epididymo-orchitis. It's differentiated from torsion by following: 1. Pren sign, 2. Deming sign, 3. Angel sign. What's Pren sign? Testis are lifted. If pain increases, it's torsion. If decreased, it's epididymorchitis. What's Deming sign? Side of torsion lies higher. What's angel sign? Transversely placed testis in torsion. Diagnosis of testicular torsion. Clinical, supported by Doppler, blood flow absent in testis. Management of testis torsion. Scrotal exploration is done. If testis viable, derotation plus orchidopexy done. If necrotic, orchidectomy done. In either case, prophylactic contralateral orchidopexy done. What's epididymorchitis and its etiology? Infection of epididymis plus testis. M.C. organism less than 40 years, chlamydia. Greater than 40 years, E. coli. Clinical features of epididymorchitis. Acute scrotal pain and swelling. Management of epididymorchitis. Antibiotics plus scrotal support plus painkiller. What's hydrocele? Accumulation of fluid in the tunica vaginalis. Types of hydrocele. 1. Vaginal hydrocele. 2. Infantile hydrocele. 3. Congenital hydrocele. 4. Hydrocele of cord. Vaginal hydrocele and its types. Accumulation of fluid only around testis. Types 1 degree and 2 degrees. Difference between 1 degree and 2 degree vaginal hydrocele. Primary equals due to less absorption, tense swelling, testis not palpable, brilliant transillumination, clear fluid. Secondary equals due to more secretion, lax swelling, testis polyble separately, no transillumination, turbid fluid. 2 degrees vaginal hydrocele is secondary to what? Epididymorchitis, tumor, trauma. Surgery for vaginal hydrocele. Lord's plication, for small hydrocele. Jaboulet's procedure, aversion and suturing of sac done. What's infantile hydrocele and its management? When sac reaches up to superficial ring. It's inguinoscrotal swelling. Management, excision of excess sac plus aversion of sac. Congenital hydrocele and its management. Patent processus vaginalis present, communicates with peritoneal cavity, hernial sac present. Management hernioctomy done by 2 to 3 years of age. Hydrocele of cord and its management. Presents as swelling along the cord. Management, excision. Spermatocele. Non-cancerous, painless, fluid-filled cyst in epididymis. Pathology in spermatocele and epididymal cyst. Spermatocele, involve epididymal head and are unilocular. Epididymal cyst, is cystic degeneration of epididymis, and are multiloculated. Fluid in spermatocele and epididymal cyst. In spermatocele, barley-colored, sperms present. In epididymal cyst, crystal clear, transillumination present. Epididymal cyst is transillumination positive. This sign is called Chinese lantern pattern. Scrotal sebaceous cysts and mangement. Due to blocked hair follicles. Don't increase risk of cancer. Management, excision.